So hopefully this will be a little bit more lively discussion about renal disease. I think we've actually had a pretty good we've actually had a pretty good overview actually by some of our colleagues already, kind of alluding to some of the great impacts of renal disease and Alagille syndrome, especially when it comes to growth. So we showed the slide ad nauseum here about frequency of the major features of Alagille syndrome. And I think, one of the thoughts that we've always had is, well, how does the kidney play into this? We used to say that there's 5 major clinical features, but what about the kidney? We need to show the kidney a little bit of love because we've talked about the heart, the liver. We will be talking about genetics. So how often is the kidney involved in Alagille syndrome, and why do we think it is involved? And again, some clues to the involvement come back to this ever-present Notch signaling pathway. And in fact, when we go back and look at it from a evolutionary standpoint or a developmental standpoint, we know that the Notch signaling pathway is actually also very fundamental for the development of the kidney. And in fact, it's actually important when it comes to the kidney segmentation and differentiation, which I'll go into a little bit about in a moment. But if we talk about frequency of the renal involvement, what I can tell you is that while if you look at the studies, they've reported a wide range of percentage of people with renal anomalies, but it probably isn't as common as Hello Kitty just yet. So I can tell you that based off of all these studies, especially in this largest study, we think that the frequency of the renal phenotype is about 40%. So, what does this mean? Well, obviously the kidneys are involved about 40% is what we think. We think this might make it a cardinal feature of Alagille syndrome, and that there's a few main structural and functional abnormalities that we typically see in when it comes to kidney involvement. And renal tubular acidosis is one of the big ones that we think about. And this is important to us too because we think that this could also potentially contribute to growth failure. And again, that's something that's very near and dear to our hearts as well. So before we get started, I'd like to spend just 1 or 2 minutes talking about, what does the kidney do, what does it look like, why we should be thinking about it. And so obviously you have 2 kidneys, and I always find this interesting because I have to give a little bit of love to the liver because otherwise I don't get to talk to you about the liver just yet. But you have 2 kidneys, right and left, and actually the right kidney sits a little bit lower than the left side, so it's a little asymmetrical, if you will. And that's just because on the right side there's this big dominant organ called the liver that happens to sit there and push down the kidney. So remarkably, actually in adults, the left kidney is actually a little bit bigger, presumably because it has a little bit more space to grow in as well. But really, both kidneys should function just the same. So when we talk about normal kidney anatomy, you can divide the kidney up in a variety of ways. And if you look at it on a structural level, we usually say that there's 3 parts to it. So there's this outer cortex right here. In the middle is the medullary system. And then in the middle, in the very center here, is the renal pelvis, or the collecting tubules. And in general, you can say that each of these 3 structural areas has a little bit of a different function. So what I mean by that is obviously in the renal pelvis, this is the collecting tubule, and this is where you collect the urine to eventually excrete it out of your body. The cortex is important for a variety of reasons. The main thing it does is it helps out with filtration, and in fact, it actually helps with the reabsorption of filtered products from your blood. Because essentially, what happens is what the kidney does is it functions as a way to filter out waste products from metabolism or from your body doing its normal processes, and it tries to keep your body in a sense of homeostasis. To say we get rid of the waste products, we hold on to those things that we need, such as the important electrolytes, salts, sugars, proteins, and if everything's working properly, then the kidneys work as kind of like the waste collectors and allow your body to get rid of these waste products. And so the cortex does a good job of helping to reabsorb things that are filtered out that the body wants to hold on to. In addition, the cortex is also the site of the production of a few different hormones that we'll go into in a little bit later, which are important in that it potentially could impact growth and blood cells as well. And then the medullary system here, if you think about it, the cortex kind of filters out, kind of reabsorbs any of the waste, any of the products that you want. The medullary system really helps concentrate the urine, and by the time the urine filters all the way down to the pelvis, it's where it gets collected and then excreted out of your body. I always debate whether or not to show this slide because on one hand I'm thinking, oh my gosh, here we go, I have to talk about embryology again, and Dr. Piccoli's already going to look at me and start quizzing me about what are the stages of embryonic development. But I do think it's actually really important for us to take a look at because it gives us a sense of at least how the kidneys develop and why we might see some of these structural defects that we see. Essentially what happens, if you think about this being an embryo, this wider part down here, we call this the intermediate mesoderm. And what it does is it's there present at the beginning when you're first developing. And the kidney is very interesting because it develops in stages, and actually what initially develops by the end of development is no longer there. And we'll go from there. So really what happens initially is this intermediate mesoderm actually creates these little segments, these little segmented things here, and they call it the pronephric system. And the pronephric system, it just makes me sound smart by talking about it, is really what it does, because it's totally non-functional. It's not even a functional kidney unit, but in fact, it's just there because ultimately it creates this primitive kidney structure that doesn't even filter any urine, but what it does is it actually stimulates the development of the kidney later on. And so what ultimately happens is this pronephric system goes away, and then the mesonephric system develops, and essentially what happens is that you have this duct system. So think of this duct as this kind of, on a grand scale, similar to that renal pelvis or those collecting tubes to collect your urine. And then this intermediate mesoderm that develops into the mesonephric system, essentially it's the tissue, the functional tissue of the kidney, if you will. And so that's eventually, hopefully, will develop into the cortex and the medulla, into the medullary system. So, essentially, once you get to this here, this is that mesonephric duct. That's that duct on the side that I was showing you initially. You develop the kidney bud, and the kidney bud slowly grows and starts to differentiate over time, and then you develop your full-grown kidney. And what's interesting here is that you see that initially starts out as one bud, and then it starts kind of arborizing or develops into this little tree-like structure, and that's integral in the setting of it kind of helps divide the kidney up into these little segments that help filter your waste products. And so if you think about, well, what does the kidney usually do? So here, if we look at this picture down here, this is just that general viewpoint of the kidneys again. Cortex, medullary system, renal pelvis, and within, kind of microscopically, within kind of running the length of this entire kidney, the structure here, you actually have the functional unit of the kidney, which is called the nephron. And so what the nephron is it's a system of blood vessels and collecting ducts that actually allows your blood to be filtered through. So if we talk about, what does the kidney do? Well, number one, it's very important in helping your body achieve homeostasis, or that balance between the products that it needs and the waste products that it creates. And one of the main things it does is it regulates body volume, fluid volume, by controlling how much water you absorb and excrete. Other things that it does is it also helps reabsorb and secrete certain electrolytes to maintain your body's total salt balance. So these are things, electrolytes such as sodium, potassium, and bicarbonate. And keep an eye on bicarbonate. We'll come back to that a little bit later. It also, the kidney also plays a role in clearing waste products. So urea or uric acid are products that are produced when your body's making proteins. And it also helps clear acid from your body as well. So in addition, sometimes it also has to help reabsorb many of the important molecules that the body filters, such as any proteins or amino acids and glucoses. But it also produces several other proteins as well, hormones. And so one of the things it does is that it actually can make the protein that actually stimulates production of red blood cells in the bone marrow. And this is something called erythropoietin. And so erythropoietin, in addition to actually stimulating, helping blood cell development, actually has been thought to actually play a protective role in a variety of other organ systems as well. The kidneys also play a role in helping to regulate vitamin D metabolism, which, as we heard earlier, is very integral to bone health and growth and development. And then it also helps to control blood pressure. So those, and I highlight these because, again, I think a lot of times when I'm giving these talks, I think of, how does this then relate back to my child clinically? What does this mean that this is what the kidney does? And I think this is really what I like to focus on, is the fact that the kidney helps control the blood pressure, it regulates vitamin D metabolism for bone growth, and is also involved in the production of the red blood cells. So if we're thinking about renal involvement in Alagille syndrome, like I said, it's involved in about 40% of people have some sort of renal manifestations. And usually you can divide that up into either structural or functional processes. And within structural, we can even say either on a macro structural level, so looking at the kidney itself, or even microscopic, looking at the nephron. So, I think by now, every single organ system, we've said this, there's a wide spectrum of anomalies that can be present, and that same is true with renal disease. So again, some children may have obvious renal disease in infancy, and others may lack any obvious signs. And so the question is, and I think this is more important for us when we think about things from a kidney standpoint, is, what are the clues that can tell us about, if the kidney's involved? And so, yeah, I think oftentimes, as physicians, we draw a lot of blood tests, and we're always saying, okay, well, the labs look good, but which one of those labs really help us focus on the kidneys? And I think there's a variety of them. So a few of them, you can look at levels of bicarbonate, or how much acid is in your body. And so if you have low levels of bicarbonate, that could be an indication that you're actually not getting rid of as much acid as you should be, and that could be an indication of kidney disease. Creatinine is a measure of kidney function. So if you have higher levels of creatinine, it could potentially suggest that the kidney isn't functioning as well. Sometimes we do urine studies. So you get a urine sample to check a urine analysis. Usually what the kidneys do a good job of holding on to the things it wants. So those things are sugars, protein, and obviously blood. But if there's any sort of injury or damage to the kidney, sometimes it doesn't filter as well, and all of a sudden you'll start seeing proteins in the urine, or blood in the urine, or sugars in the urine. Another thing that we can look for on the urine studies is to see, do you have an infection? Do you have a urinary tract infection? Because sometimes some of the structural anomalies with the kidneys, or the whole kidney system, is that you might be prone to reflux, or rather, the urine in your bladder doesn't actually always go out, but it refluxes back up to your kidneys, and that can actually cause some scarring, damage, and actually put you at risk for getting infections. And so that's something else that we frequently screen for, is to say, is there any signs of a urinary tract infection? And then on top of all that, you have other renal diseases in which, you have a structural defect of the kidney, but you're otherwise clinically doing well, and you only find it because we're getting an ultrasound of your belly for some other reason as well. Key thing here is to know that most people with Alagille syndrome do not develop kidney failure. We'll go over the one or two instances in which we need to keep that in mind a little bit later. So this is a little bit more in-depth list of, what do we mean as physicians when we say, we're looking at renal function. What are the things that we're looking at? So looking at levels of electrolytes, potentially, specifically the sodium and potassium levels, because your kidney filters those electrolytes. We already mentioned the level of acid base in the blood by looking at the bicarbonate. BUN stands for blood urea nitrogen, and so that's another way for us to really look at kidney function. So normally that should be fairly low, but if for any reason it's elevated, it could be suggestive of renal injury. And the creatinine, which we talked about earlier, is a good marker of how the kidney is doing at eliminating breakdown products. And the list goes on and on. I mean, you can look at sulfates and phosphates, which is a good way to look at waste products. You can look to see if things are leaking into the urine that aren't supposed to be there. And then there's other things that you can look for too, including, is how's the kidney doing in relationship to activating vitamin D? Because sometimes if you have chronic kidney disease, you may not be telling your body to produce or utilize vitamin D as efficiently, and that could actually also be impacting bone disease. So, what does evaluation for kidney involvement entail? It entails a variety of testing. So we've talked a lot about the blood tests that we can check. There's also urine studies, which we talked about as well. Sometimes if there is concern on any of the blood tests that the overall kidney function could be a little bit decreased, we can actually do measures of kidney function. And so there's a few ways we can do that. One way is to look at overall function using this 24-hour creatinine clearance, because again, creatinine is a way for us to measure how well the kidney is excreting and filtering products. There's actually newer measures to actually directly measure kidney function instead of looking at creatinine, and what they can do, there's these scans, like DTPA scans, which essentially they're nuclear medicine scans that tell you, if we inject a specific amount of contrast or dye into your system, how quickly do the kidneys excrete it, and that's a good way for us to measure de facto urine or kidney function. There's other imaging studies that can really help us discern if the kidney is involved, both structurally. You can look at an ultrasound and an MRI, and then functionally, you can look at, if you're worried about you have reflux or poor flow of the urine out of the ureters, you can look at things like a Boyden scan or a IPP as well. So when we think about renal involvement in Alagille syndrome, what are the main things that are involved? Well, in the biggest study that we looked at, the one where we found that about 40% of people with Alagille syndrome have some form of kidney involvement, we found that, like I said, you can either break it down into a structural issue, and even in structural, the question is, does it affect the kidneys themselves? Does it affect the ureters, which are these ducts that connect the kidney to the bladder? And so the question is it kidneys or ureters that are involved? And the most common lesion that we find is something called a dysplastic kidney, which I'll get into in a little bit. And we saw this in almost 60% of the people who had renal involvement. The kidneys were dysplastic. Dysplastic is a medical term that essentially means abnormal development. And essentially, if you think about it, there's a arrest of development, or rather the kidney just doesn't fully develop, so you don't really have any good functioning kidney tissue. And it can take on a variety of forms. Sometimes you can have cysts in the kidneys, sometimes the kidneys can just be small and non-functional. And so it's really, think of it as more of a generalized term in terms of just the kidney hasn't developed appropriately. And again, we think that the reason for that is because if you have mutations in the Notch signaling pathway, clearly this pathway is important in differentiation of different organ systems, and could that be one reason why we see some of these developmental anomalies in the kidneys. Number 2 on the list is actually renal tubular acidosis, which is a functional challenge of the kidneys in terms of it just has trouble really helping to excrete and get rid of the acid. And again, this is very important because if you have renal tubular acidosis, this can actually impact growth, number 1. But number 2 is actually on the things on this list, it's actually one of the things that in theory should be fairly easily correctable. If we give you some bicarb, and by taking some extra bicarbonate, you can actually decrease the overall acidity of the blood to help, and then hopefully that can actually help you grow better in the future. So it doesn't really fix the underlying acidosis problem, but rather we can address the acid-base imbalance. Next 2 on the list, vesicoureteral reflux or obstruction. This is more relating to challenges with the ureters, or those connecting ducts. if we take a moment just to talk about some of the different renal manifestations that we might hear about, I find pictures help me out a lot. So renal hypoplasia is something that that you may hear of. It's a little bit different than a dysplastic kidney, but rather hypoplasia just means it's poorly formed or not fully formed. And essentially what happens is a lot of times if you think your kidney should be nicely formed in this this normal size, it just doesn't form as completely as we would expect. And so what happens is you actually get a very small kidney, but it still functions in terms of it has the normal, it has the nephrons, or those the functional unit of the kidney. It's still there and it's still doing what it needs to do, but you just have less number of them, and that's why your kidneys are smaller. And so we see this on occasion in which we actually have children or adults who have just one smaller kidney, and we know that it can be associated with Alagille syndrome. Renal dysplasia, like I mentioned, this is the most common renal manifestation, and so I think of it as because you have problems with development, or you have arrest of development, meaning the kidney doesn't fully form. What you end up with is you have these very primitive or abnormal kidney structures, including the kidney tubules. Sometimes you actually see cysts in the kidneys. You can actually see scar tissue form in there. And so if you think about if you have scar tissue in the kidney, the scar tissue actually replaces the functional kidney tissue, and as a result, your kidneys just don't function. And so here, this is a picture. This is actually a hypoplastic kidney, and this is a dysplastic kidney, basically showing that it has maybe the kidney still looks normal in size, but the tissue inside isn't functioning the way that we would expect. This here is a picture. It's a little gory. I apologize. That's why we saved this for number 2 after lunch, and not number 1. But this is actually a cystic kidney, and so lots of and so if you think of cysts or big fluid collections, instead of having functional tissue, you just have these fluid or air pockets of non-functioning kidneys. So if you actually took that bag of cysts that we just saw and actually looked at it under the microscope, you would see this. And I promise you I won't test you over this afterwards, but this is basically everything that a kidney should not look like under the microscope. And I find it not to be very helpful unless we actually know what a normal kidney looks like. And so that's normal on this side there. So these are like cystic structures, and you can tell this here, right there, that's called a glomerulus. What that is I keep on going back to this nephron. So basically, the blood from your body goes to the kidney and then gets filtered through a collection of blood vessels and the blood vessels function to filter out the waste products. The main blood vessels that do the filtration process initially is called the glomerulus. So it's like a big bag of blood vessels within the kidney. And it's organized in a way as such that it kind of allows your blood to kind of slowly flow through and filter out some of these waste products. As you can see here, this is what a normal one looks like. This is what an abnormal one looks like, just basically saying it's just not as well organized. There are other diseases as well of the kidneys that we see. Nephronophthisis, also known as medullary cystic disease complex. It's another relatively common disease of the kidney that we see in Alagille syndrome. And the main thing that we see here is that we actually see these you can see these are kind of like little cystic deposits, basically, between the cortex and the medullary system. And what happens here is that, again, think of it as any time you have cysts or any other type of material replacing normal kidneys, it's going to impact normal kidney function. The key difference here is that instead of getting a really big, boggy kidney because you have cysts, you might actually have a normal appearing kidney or even a smaller kidney. The challenge is because you've replaced functional kidney tissue, your kidney is now unable to concentrate urine. And so remember earlier we said the kidneys can be divided up into 3 kind of structural places: the cortex, the medullary system, and the pelvis. The medullary system is the part that really focuses on concentrating urine, And because essentially in medullary cystic kidney disease, the medullary system is replaced by these non-functioning cysts, you no longer have good viable functioning tissue to concentrate your kidneys, or concentrate your urine. Take a quick moment to talk about renal tubular acidosis. And so this is actually, it's a medical term that is used to describe what happens when your kidneys fail to really effectively excrete acid from your body. So acid is a waste product that builds up and what the kidneys do is it helps get rid of it through your body. And if you're not effectively excreting the acid, sometimes the acid then hangs out around your body and it can actually have a variety of impacts. The main things that you can see is that, number one, you can actually see poor impact on growth. You can actually be slower to grow. You can also see bone disease because of acid-base imbalance. And sometimes you can also develop kidney stones or chronic kidney disease if the acidosis goes long-term uncorrected. And so this is actually one of the conditions in which, if children are just generally smaller in stature that we check for. And so I point that out to say that, clearly having a good acid-base balance is very important for overall health. And it's one of the things that I think one of the easier things for us to screen for, whether it's, by a urine test to say, what's the level of acid in the body? And if it's high, looking at the serum, looking at the blood test to correlate that, and then to see, are there things that we can do to treat it? The key thing here is that it's purely a functional issue. There's no obvious structural abnormalities of the kidney. So doing imaging studies such as an X-ray, ultrasound, CAT scan, those aren't going to tell you if the kidneys are having trouble getting rid of the acid. Like I said, the key thing is that it's treatable by supplementation of bicarbonate, and anyone with renal tubular acidosis, we highly recommend them following with a nephrologist. So one of the other kidney conditions that we typically see, or we can see, is this glomerular misangiolipidosis. And the way I think of this is that, and I really like this disease for a variety of reasons, but mostly because I think I can finally relate it back to the liver a little bit. But from a liver standpoint, we always talk about cholestasis, and if you're cholestatic, we know that also sometimes we can have higher lipid levels or triglyceride levels. And what happens is that, in this particular disease, you actually get deposits of these fat cells, the lipids, into the cells of the kidney. And so then that actually causes, the non-functioning kidney. And again, it can affect filtration and function of your kidneys. And usually this is something that develops over time, and you can see it with more advancing age. And again, that makes sense to say, well, if you have high circulating triglyceride or fat levels or lipid levels in your body for a long time, and we're unable to get those levels lower, then over time the fat's going to deposit in your kidneys, and then that's going to lead to this kind of slow chronic irritation of the kidneys that will eventually impact kidney function. And what's interesting is that some of the studies have shown that the severity of this disease could actually be related to the degree of cholestasis, which makes sense on many levels if we look at what we know about liver disease and the fact that children who are more cholestatic sometimes also have more challenges with their lipid levels as well. One last thing, I think I glossed over this very early, but clearly the kidneys also play a role in regulating blood pressure as well. And so that's one of the other things that we're always looking at from a, what did the kidneys do, and how does this keep me or my child healthy? So one of the common things that we can see is something called renal artery stenosis. So again, stenosis means narrowing of the blood vessels. And as we've heard in some previous lectures, we definitely know that JAG1 or Notch2 can potentially impact. We see them in the blood vessels, in the vascular tissue, and so again, not a surprise that we see some vascular involvement in Alagille syndrome. In renal artery stenosis, what happens is the renal arteries are a little narrowed down, and the downstream effect of this is this actually leads to higher blood pressures. And so it's something that's very important to see early on. Here's a nice angiogram picture, which is basically we're injecting dye into the arterial system. And you can see here on the left side, nice open renal artery. And then on the right side, all of a sudden here, you see a little filling defect that you can't quite trace all the way through. And that would be the area of narrowing or stenosis. I bring this up just because, if you do have renal artery stenosis, this could be the reason why you have high blood pressures, and it's something that we definitely want to address as soon as possible. So now that we've reviewed some of the structural and functional defects of the kidney, the question is, well, what happens in Alagille syndrome, and what do the outcomes depend on? So the outcomes can depend on a variety of things. First of all, is just one kidney or both kidneys are affected? And if you have one functioning kidney in general, that should be enough to allow you to have normal kidney function. The outcomes can also depend on severity and extent of the involvement, so especially if you have cysts or other deposits in the kidneys. One thing to keep in mind is that in general, if you have a single or what's called a simple cyst of the kidney, so just one little balloon, that really shouldn't cause any sort of long-term functional problems to the kidneys. It's more if you have multiple cysts that then replace the kidney tissue, that's when we start running into challenges. Similar to a lot of the other organ systems, early evidence of serious kidney involvement is associated with worse outcomes. And obviously, depending on your type of kidney disease, if you have severe cholestasis, that could also impact overall outcomes. So things to consider, things to keep in mind are that renal disease can contribute to growth failure as well as bone disease. And even though renal failure is not frequently seen, it can definitely occur. High blood pressure or renal hypertension is something else to keep in mind as well. Clearly, if you have renal disease, the kidneys are very integral in helping to clear some of the medications that you might take. So, whenever you take a medicine, it's either usually cleared either by the liver or the kidneys, and this is important because, especially in the realm of transplant, if anyone needs to eventually get a liver transplant, some of the immune suppression medications we use for liver transplantation are actually cleared by the kidneys as well. And so if you have underlying renal disease, that's something we want to know and keep in mind to say, can we minimize the exposure to any sort of medications that might irritate the kidneys if we're thinking about the need for a transplant further down the line? So things that we have found to be very helpful is to really get a good baseline understanding of what the renal involvement is. And so that includes getting a baseline renal ultrasound to say, are there any obvious structural defects or structural anomalies that we see? Pretty simple test, and oftentimes if you have liver involvement, you're already getting an ultrasound, so it's pretty easy to swing down and take a look at the kidneys. Obviously, also monitor renal function with serial blood checks. So this is all blood work here that we can look for, looking at the creatinine or the bicarbonate or the acid level. Also look at the urine, do routine urine studies as well to see how's it filtering the proteins to make sure there's no proteins in your urine, no signs of infection. And then keeping in mind that even though we know that with Alagille syndrome, children tend to follow a different growth curve, and growth is always an issue, but to know that there's also an abnormal for growth for Alagille syndrome as well. And so if growth is a challenge, let's make sure that we're really looking at how the body's clearing acid, because that could be a key point right there. So the take-home points, I think, from a clinical standpoint would be, number one, is there a concern about kidney function or having a single kidney? Because if there is concern about kidney functions, that we may need to limit the any potential medications that can be irritating to the kidneys. Number two would be, is there any concern for renal tubular acidosis? Because this clearly not only does it impact growth, but it's one of the few kidney manifestations that are treatable with bicarbonate. And then number three, what's the blood pressure? Do we need to be worried about renal artery stenosis? Because clearly, if you have renal artery stenosis, that could be a cause of higher blood pressures. And that's something else that we want to always be mindful of. And so I think that should be it for the renal talk. Any questions? Yeah.
Against an artery where it would cause like a kink or a spot where it would rub or rupture?
So very good question. So the question is that, you know, if you have an enlarged spleen or liver or portal hypertension, if you will, you know, what's the impact of it? And, you know, specifically, I think you're asking, you know, could that lead to any evidence of bleeding or does it impact other organs, correct? Yeah. So I think there's a couple ways to look at that. You know, number one is, you know, with an enlarged spleen and liver, usually you're thinking portal hypertension, which is a reflection of overall liver disease. If you have portal hypertension, what happens is that your blood tries to go the path of the least resistance. And so the blood kind of comes up. So this is all, we're talking all about the venous system right now. And so really, you shouldn't have any direct impact to your arteries. But from a venous system standpoint, the blood kind of comes back up from the body and the legs and filters into the liver. But if you're having higher pressures in the liver, it preferentially backs up. And one of the first places it's going to back up to is actually the spleen, because the spleen is one of your most elastic organs, if you will. It's a big bag of blood vessels, and so it's easy for the blood to back up into the spleen. Once you get enough, once the spleen gets big enough, the pressure starts to change a little bit where it's no longer easy for the blood to flow back into the spleen, and then the blood has to say, well, I can't go back into the spleen. It's hard for me to go up through the liver. Is there an easier pathway for me to go? And so sometimes what will happen is that you'll develop these shunts. And so to say, you know, these pop-off valves to say, how else do I release this blood pressure? One of the common things we'll see, and I don't know if you're familiar with it, is esophageal varices. So basically, the body says, well, if I have such a high pressure system, let me just create blood vessels that can connect me to other areas that just help drain the blood, basically. One of those areas is you actually end up getting blood vessels that go from the spleen, or kind of roughly around the spleen and the liver, and they kind of go up into like running right alongside of your esophagus. And they actually run right on the surface of the esophagus. And so those are at high risk for bleeding if you develop them, because, you know, the membrane, the blood vessel membrane is so thin that, you know, any higher pressure through it, or something just kind of scrapes along it, you know, the wrong way, you could have what's called like an upper GI bleed. So yes, you could definitely see bleeding from that standpoint. The other things is that sometimes instead of creating blood vessels to go up, sometimes you'll preferentially create smaller blood vessels to kind of try to get through the liver, or sometimes you'll even see a shunt creating from blood vessels going from the spleen into the kidneys, essentially, because the kidneys, if you drain your blood from the spleen to the kidneys the blood flow from the kidneys can actually bypass the liver and go directly back to the heart. So it's kind of like a shortcut, if you will. The downside to that is that then all that blood doesn't filter through your liver instead. And so that's a really long-winded answer to really say that yes, with the higher blood pressures, you can definitely see changes in the blood vessels depending on where the blood vessels pop up that might put you at risk for bleeding, but it really shouldn't impact blood flow into any other organ system, because we're talking about from a venous standpoint, and the main impact you worry about is to say, you know, one, are you at risk for bleeding, and then two, if you shunt away from the liver, then you end up having a large portion of your blood not being filtered by the liver, essentially.
And all those blood vessels building in the spleen, just laying there, does that in itself create a problem?
So yeah, I think it depends on who you talk to. In general, yes, it could cause a problem. Is probably the best way to answer it. And the reason is because, you know, if you have if your spleen normally nestles right underneath your rib cage and it's protected, and so anytime you get more blood into your spleen, the spleen is going to get bigger. It's going to kind of protrude below the rib cage, and then that's when you know, in other diseases, like if you have mono or kissing disease and you hear like, you know, the big spleen, those are the children we say, you know, let's avoid contact sports, because if you get like blunt trauma, you know, you get hit by a baseball to the spleen area, you could be at risk for rupturing those blood vessels there. So I'm not too sure if we've ever really seen a case of splenic rupture that's been associated with a big spleen from portal hypertension. But I think as clinicians, we all try to take the cautious approach to say, you know, if you do have that big spleen, wear a spleen guard or a protective, protective guard over it, whether it's foam or a more firm piece of equipment, just to try to protect us from that standpoint.
Does anybody have another question? I do.
Excellent.
Elena has taken Ursodiol
Mm-hmm.
for 21 years now, and I guess my question is, you know, how does that affect the kidneys at all? Is there any information about whether that affects the kidneys?
Yeah, so very good question. So, you know, so one of the medicines that we commonly use from a liver disease standpoint is Ursodiol or Actigol. And essentially what it is it's designed to promote bile flow, basically bile flow through the liver. And so hopefully to say, you know, if it's because you're having poor bile flow through the liver and that's why it's irritating your liver, then if you give something to kind of promote flow, the bile flow, then maybe it doesn't irritate your liver as much. Because of that, you know, usually the, you know, in my understanding, it's the medication isn't really cleared by the kidneys. You know, it's just because you take it, it kind of helps push, because what it is it's actually a synthetic bile salt. Like, you know, urso really means bear, so like back in the day, it's like, it's almost like bear bile. So you're taking bear bile, and what it does is it just kind of helps promote, your body kind of puts it into your biliary system and helps just flush things along. I mean, now it's not from bears, but I mean, it's because of the same concept. It's a synthetic bile salt to really promote the flow. And so because of that, it really doesn't get seen by the kidneys, and so it shouldn't really impact the kidneys, to my knowledge. Sir.
Two questions.
Okay.
First of all, when you're talking about the 40% of people
Mhm.
who have kidney issues, does that include people with renal artery stenosis? And the second is, could you explain just as non-technically as
Mhm.
possible, how does the kidney regulate blood pressure?
Okay. Yeah. So two questions. First of all, you know, 40% of people with Alagille syndrome have renal involvement, and you know, does that include, is renal artery stenosis included in that number? And in our, let me see. So if you look at here, it is included in the number, and actually it's like we had 2 people with it, so like, you know, 2.7% of, or 3% of the total number of people with renal disease, we found renal artery stenosis in. So short answer to that is yes, it is included in it. The second question is, you know, how does the kidney help regulate blood pressure? So there's a few different ways to do that. Essentially, think of it as the kidneys serve a variety of functions, but it has these receptors on the kidney that basically says, am I seeing as much blood flow as I expect to be seeing? And if for any reason you're not, so if you're expecting to say, you know, I'm supposed to see a liter of blood flow a minute in my kidneys, for example, and all of a sudden I'm only seeing half of that amount. And so your kidneys will say, oh, well, am I not seeing that amount because I'm just not pumping enough blood to the rest of my body? And that's why not enough blood is circulating back through the kidneys, because I'm only having half the flow. And so then it will have this compensatory mechanism to say, okay, if that's the case, then how do I increase blood flow to the rest of the body? Well, let me increase my blood pressure, because if your blood vessels squeeze down, in theory that should move blood forward a little bit more. And essentially that's how it works. So basically I think of it as, so if you take that back to renal artery stenosis, you know, it's not really that you're not getting enough blood to your kidneys because your heart's not pumping effectively, or you're still seeing the normal amount, but it's because it's a structural issue where the blood just doesn't get to the kidneys. Your kidney kind of misinterprets that to say, oh, I'm not actually getting enough. Your kidney only sees I'm not getting enough blood, but it doesn't know the why behind it. But its solution for it is to say, well, let me try to increase the blood flow to me by increasing the blood pressure. Does that answer?